Hi, my name is Raanan, and I will be doing a presentation today on alcohol abuse. In addition, I will also be going over the treatment for people who abuse alcohol. An introduction to alcohol as a substance. It is the most commonly used substance in the United States. Usually, this is used for recreational purposes. It is currently legal, but despite that, it can cause physical, psychological, and social harm if it's misused. The chemical compound is called ethanol. The main types you'd probably see would be beer, wine, and spirits, which tend to have the highest concentration. Other names that you might hear would be liquor and booze. Alcohol is a central nervous system depressant. It increases GABA activity, causing inhibition. It affects multiple systems, both short term and long term, and this includes the brain, liver, heart, and gastrointestinal tract. It's made via fermentation. The DSM 5 currently has three diagnoses for alcohol use. There's alcohol use disorder, alcohol intoxication, and alcohol withdrawal. So the history of alcohol use dates back to almost 10,000 years with evidence found in China, Mesopotamia, and Egypt. It's usually used for celebratory purposes in addition to healing and ceremonies. In America, there was a prohibition between 1920 and 1933 where alcohol was illegal via the 18th Amendment. It has a well documented use throughout human history. It is also popular among veterans and in war situations to combat stress and as a way of socializing. Alcoholism in general receives a lot of stigma and the term alcoholic, so people generally like to use the term alcohol use disorder. Currently, about 84% of people who are ages over 18 and older in the United States use alcohol across the lifetime. Alcohol use disorder can be labeled as low risk or high risk. Usually, the high risk is based on the amount that somebody drinks and binge drinking as well. Alcohol use disorder amounts for 200,000 hospitalizations every year, with 7.5% of emergency room visits. It affects about 29.5 million people, and that includes people 12 and older. And out of that statistic, only 7.6% receive treatment. There are many risk factors in vulnerable populations for developing alcohol use disorder. Psychiatric comorbidities include bipolar disorder, which has a very high comorbidity, PTSD, panic disorder, anxiety disorder, and depression. Then you have psychosocial factors such as stressful events, losing a job, a home, a divorce, social isolation. Environmental factors, poverty, having a history of jail time, inequality. Then you have your genetic markers. There's a higher rate of drinking if there's a family presence of drinking. Your cultural populations, such as the veterans who tend to celebrate with alcohol. And if you're coming from a culture that has a high rate of drinking, then you have a higher likely chance to be consuming alcohol. And then, of course, if you're introduced to alcohol at a younger age, you have a higher tendency to abuse alcohol. Your short term side effects include intoxication that would cause functional impairment, poor coordination, slurred speech, a loss of balance, loss of memory, and blacking out. You may also experience feelings of euphoria and decreased anxiety. Behavioral changes can include increased aggression, mood changes, judgment impairment, poor decision making, such as driving while under the influence, and hallucinations, but those tend to be more rare. In rare instances, you can go into renal failure, central nervous system depression, coma, especially if the use is very heavy or it's mixed with other sedatives such as benzodiazepines. And usually, coma levels are when you have blood levels greater than 300 milligrams per deciliter. In addition to that, short term side effect also has a high suicidality risk due to the impulsivity increases. Long term side effects affects almost every system in the body, and the list is endless. For your GI system, you have your hepatotoxicity, so you could have liver cirrhosis, you'll have elevated liver enzymes, hepatitis, jaundice. You could also develop pancreatitis, ascites, and esophageal varices, which have a high risk for bleeding. Your hematological side effects can include thrombocytopenia, anemia, B12 and folate deficiencies. Neurologically, the thiamine deficiency can cause Korsakoff syndrome and dementia. Cardiovascular, you have hypertension, atrial fibrillation, and then this goes into respiratory with obstructive sleep apnea. Your coronary artery disease risk increases. You're also at an increased risk of developing multiple infections, and drinking leads to physical injury and increased risk for suicidal behavior. Physical injuries are usually due to falls or other types of injuries during intoxications. So, between the long and short term side effects, alcohol cannot be stopped suddenly for people who drink heavily, otherwise, they will encounter withdrawal symptoms. Withdrawal symptoms typically start within hours after the last drink, with a peak at about 72 hours after the last drink. The symptoms include autonomic nervous system hyperactivity, which presents with sweating, tachycardia, and tremors. You'll also see insomnia, nausea and vomiting, increased anxiety, agitation. People can develop hallucinations. The tactile hallucinations are very common. They might be itching or feel like they have bugs on their skin. In addition to that, they also go into delirium tremens, which is an altered mental state. And finally, there's a high risk for seizure and fatality if the withdrawal is severe enough. The signs and symptoms of abuse upon assessment include the symptoms of intoxication, and this can be based on tolerance and the amount that the individual consumed, and which is based on the blood levels. Usually the range is between 20 to 300 milligrams per deciliter. Your physical symptoms include functional impairment, poor coordination, slurred speech, loss of balance, loss of memory, and blacking out. Psychologically, your lower doses may be more stimulating for the person, while the higher doses are more sedating. And then people tend to have poor judgment, poor memory, cognitive delays, disinhibition, and euphoria. High toxicity levels will present with unresponsiveness, coma, and possible death. That's when your blood levels are 300 or greater. Some of the social signs and symptoms can include poor social functioning, poor family relationships. The individual may not be able to control their drinking habits. They can't stop, and these behaviors tend to be noticeable by other people in their lives. So, the potential for overdose is definitely heightened when it's abused with other sedatives like sleeping pills, benzodiazepines, and opioids, anything that would affect and cause respiratory depression. Binge drinking also has a high probability for overdose. Drinking a very heavy amount in a short period of time can increase those blood alcohol levels dramatically. This can lead to respiratory depression and coma in and of itself without the use of sedatives. There's also high risk for suicidal behavior while intoxicated, and this increases with toxicity levels. This is because alcohol can enhance feelings of depression, aggression, impulsivity, judgment impairment, reckless behavior, and can have a decreased fear of dying. It can also cause arguments in relationships while intoxicated, leaving people to be impulsive. It is the most likely suicide weapon when there's a firearm involved. So if somebody does use alcohol consistently and has exposure to a firearm, then this could be very dangerous. So now we're going to go into treatment, and treatment goes into two phases. You have the acute detox treatment, which includes withdrawal management. This is usually based on some kind of scoring, which is commonly called the CWA, but there are other scales. And the medications used to treat this is your benzodiazepines, lorazepam, diazepam, chlorazepam. These could be given intravenously, intramuscularly, or by mouth. Then you have propranolol and clonidine. You could use to treat side effects such as hand tremors. And the goal is to prevent seizures and just ease the withdrawal. Your chronic management is abstinence. Once the withdrawal period is over, then you want patients to stay abstinent from alcohol. Naltrexone is your first line. It decreases craving, and this affects the reward system in the brain for alcohol use. Then you have acompressate. It's another first line for alcohol use disorder. It works as a GABAergic and NMDA antagonist. And your second line is disulfiram. It's an acetaldehyde dehydrogenase inhibitor. This causes a distressful reaction when alcohol is ingesting, creating negative reinforcement. So patients, after taking this and decide to drink, will experience some pretty bad symptoms such as vomiting, tachycardia, and palpitations. The non-pharmacological treatment, you always want to assess the patient. The common scoring is the CAGE assessment to assess how much drinking is involved. Then there's a determination if the patient's going to need inpatient rehabilitation, and this depends on the severity of the withdrawal, their safety, if they're suicidal. If the patients are safe enough to handle withdrawal symptoms, then they can be treated on an outpatient basis. Once the withdrawal phase is over and they're physically functional, you want to start to engage with cognitive behavioral therapy or another form of psychotherapy. And you also want to include family therapy. Then you have your support groups such as Alcoholics Anonymous, and you always want to do a continuous screening assessment. Then in addition to this, you want to provide them with sponsorship and coping mechanisms to help them learn how to live and deal with stressors as they go on to become more independent. Education is patient education is focused on medication education. So if they're going to be admitted or be treated for acute withdrawals, you want to just explain to the patients what kind of medications they're going to receive. The benzodiazepines are just used to control their symptoms for short term until the withdrawal subsides. And then after that, their focus is on abstinence. Naltrexone is an opioid receptor antagonist. It could take a few days to weeks to work. It decreases reward activity, Your side effects include nausea, decreased appetite, anxiety, and maybe injection in the site. Urocompressate reduces glutamate, increases GABA. It can be augmented with naltrexone. They often are used together. Side effects include anxiety and depression, nausea, diarrhea, and suicidal ideation. Disulfur is for maintaining abstinence. You really want to educate your patients that if they do drink, they will have some pretty bad side effects. And then, of course, normal side effects without alcohol consumption includes a metallic taste in the mouth, sedation, and possible dermatitis. Finally, you want to teach patients about lifestyle modifications, and this includes psychiatric medication adherence. Treating comorbidities may also be included. Attending therapy, support systems, physical exercise is great for recovery, and maintaining a healthy lifestyle with a healthy diet as well. Referrals will start initially as a possible inpatient referral to manage the withdrawal. This requires 24-hour supervision for safety. Then, of course, medical team. There's a lot of medical comorbidities and complications that come with alcohol use depending on the patient and how long they've been using. You also want to possibly refer them to an addiction specialist. These are people, therapists, and psychiatric providers who specialize specifically in substance abuse and are good at managing these disorders. Then you have your faith-based recovery groups. These could be helpful for specific patients. You have social services as well. It's a good referral for housing, employment, transportation, kind of helping people bounce back into life who may have lost some things. And then you have psychotherapy and counseling to maintain abstinence. So your follow-up comes in several phases. During the initial phase, patients are very likely to relapse, so it's good to follow them up on a frequent basis. Usually, it's recommended to monitor them weekly, monitor withdrawals, protracted withdrawals as well, and medication efficacy and their side effects. Then they go into a stabilization phase, which is between 4 weeks to 6 months. This is where they learn new coping mechanisms and relapse prevention. And once they've achieved 1 year of sobriety, then they enter into a maintenance phase, and that would require quarterly appointments. Then you have your continued care, relapse evaluation, abstinence. You always want to check patients for medication adherence, any new stressors that come into their life, and how they're coping with them. And then you want to evaluate patients for protracted withdrawal, which can range up to 6 months after stopping alcohol. In conclusion, it's important to understand that alcohol is available recreationally and it is culturally accepted. As providers, it's important for us to stress the importance of drinking responsibly. This includes public education campaigns and awareness, alcohol abuse prevention, coping strategies, and educating populations who are at a high risk for developing alcohol use disorders. Your best treatment approaches are early identification and early interventions, and it's always important to approach patients with compassion, therapeutic communication, empathy, and advocate for their safety as good practice.